excellent organization here that invited me to join this meeting, and it's a great pleasure to be here. We had some excellent cases in the morning, and in my lecture I just would like to present cases from our department, actually, and it seems that we have all the same challenges, and the challenges in diagnosis of mycosis fungoides. So as Julia, as Karisbek said before, we have an average time to diagnosis between 3 to 6 years, and then this has been proven by Proclipi, and sometimes early stage disease is difficult to diagnose. Even we have cases that in early patch stage MF we have detectable clonal rearrangement with the current PCR method, but maybe with what Jasmine just explained to us, maybe with high throughput sequencing, we will be able to detect these cases. And so it takes some time from the patient. When the symptoms come, the patient feels the symptoms, then it's a time that with self-management, then it's sometimes treated for eczema or psoriasis, and then it takes some years until the proper dermatologist sees the patient, and then the workup of the patient starts with biopsies and management of this chronic disease. So one important also issue is that it's difficult, even if the patient reaches the dermatologist, it's also difficult to make the diagnosis, and we are based in this criteria for diagnosis of early MF. And as you can see, there's a scoring system, and we use it in the practice when we have difficulties in diagnosed patients, and there are basic criteria and there are additional criteria. So the basic clinical criteria is it's when patient has persistent progressive patches or skin plaques. So this is very important, and as we saw today in the clinic, these very interesting cases, sometimes they lack these additional criteria, so they may not have a non-sun exposed location, and maybe they are symmetrical, and then their size and shape, there is no lack of variation, and poikiloderma may be present in some cases. And also pathology is very important, and the superficial lymphoid infiltrate, but there is again epidermotropism and lymphoid atypia, and the presence of clonality is really very important, and it's actually very important to consider which method we use. Maybe, I mean, with the new NGS, we might detect more cases with clonality, and immunohistology, histochemistry is also very important to detect the lack of some biomarkers. And starting with the location, it seems that sometimes it is easy, but sometimes might be difficult to differentiate between scalp lesions, and we have scalp location in folliculotropic MF, but also we have scalp in psoriasis, and there are differences in histology and clinical presentation usually. Also, we have MF in palms and soles, and sometimes it seems that 10% of the patients with MF present with MF on the palms and soles. So this is difficult to diagnose if in patients with lack of other skin lesions, and the differential diagnosis is between eczema and psoriasis, and we saw today in the clinic also a patient like this. So when we consider this patient, it's very important to go back to the patient history. If the patient has an history of a disease like psoriasis, eczema, physical examination is very important, even if lymph node examination, if the lymph nodes are enlarged, is it dermatopathic, or if this is an infiltration. And of course, the skin biopsy is very important, and we insist that we have to have a definite skin biopsy and then start the treatment, because sometimes if we are not sure about the skin biopsy and the result, then we should not start any treatment, as was said before, that may jeopardize the management of the patient. I will present some cases that we have in our clinic, and I think they're very interesting. And this is a patient. He was treated for psoriasis, and as you can see, we're a dermatologist. I mean, he has some lesions that if you can see, they are quite well demarcated. They have hyperkeratotic scales, and this from a clinical point may go with psoriasis. And he was treated with cyclosporine, and he had an initial response, and then he didn't respond very well. They updosed his cyclosporine, and he came he had a lesion on his chin, and they stopped cyclosporine. He came to the hospital because he was febrile, he had the fever, he had the MRSA positive swabs, and he was put on antibiotics, and he had a negative flow cytometry, but then this lesion was tumorous lesion, and we biopsied this lesion, and this was MF tumor stage. So this patient had plaque MF and tumor stage MF at the time that we saw the patient. However, the clinical presentation in the initial presentation of the disease was very mimicking very much psoriasis. And when a patient like this visits a private dermatologist, sometimes they skip this diagnostic challenges and they go through to the diagnosis of psoriasis. And this patient had actually TSCB, and he cleared completely since then, and we have not had any relapse from his skin. So this is another case. We saw another case today, as I said, and this is not eczema, this is not psoriasis, this is not fungal infection, and this was an MF plaque, and this patient had a local radiotherapy, and since then he had a complete CR. So a single unilateral lesion on the left foot, and was this diagnosis. So another patient with metabolic syndrome, and had that diagnosis again of psoriasis, and you can see how well demarcated and how much MF can mimic psoriasis. And he had large nodes, lymph nodes, and we had a core biopsy because the lymph nodes were above 1.5. They were to 23 millimeters, and it was negative. There was a reactive lymphadenopathy, and the patient has skin histology. He has had MF with the presence also of CD30 positivity. This is H&E, but this you can see CD3, CD4 positive epidermotropic lymphocyte with epidermotropism, CD8 negative, and again, and he was positive for CD30. So there is knowledge that patients with psoriasis have a high risk of lymphomas, but and it's shown that the most prevalent of this is MF. So a patient with psoriasis might have lymphoma, and patients with psoriasis have immunosuppressive treatment. So both of these factors are risk factors for a patient that does not respond to treatments for psoriasis to be considered as a possible candidate for a new biopsy and for the diagnosis of MF. So as dermatologists, we have to be very careful with the diagnosis before we initiate any treatment. And this is the paper by Gelfand that was shown that the strongest association of lymphoma with psoriasis was CTCL. And actually, we performed in our department a study in patients with psoriasis and MF, and it seems that there was a clear coexistence in some patients, and because it was histologically confirmed psoriasis before the presence of MF. So in some patients, as we discussed today in the morning, they may have psoriasis and MF, and other patients might have MF from the beginning, and this has been misdiagnosed as psoriasis. So this was a multi-center study from several centers, including EORTC centers, and there were 19 patients with MF, and this patient received biologics. So we tried to see if biologics were, impairing and the disease course and make this patient progress. And actually we found that most of the patients were at anti-TNF, but there were patients also with receiving inhibitors of interleukins. So we found that in some cases with early MF, anti-TNF might not worsen the disease, but MF can be driven by immunological changes induced by TNF, and also disease progression was even worse with inhibitors of interleukins. So these patients were either misdiagnosed or not diagnosed. And the last case is a patient that actually was referred to me by my colleague. We do together, the hematologist. And this is a patient with long-standing history of hyperkeratotic eczema, several plaques on his body. And he was diagnosed as atopic dermatitis, psoriasis, and then he had erythroderma. And he was referred to him, and then he referred this patient to me because he said there was a phenotype in his flow cytometry he didn't really like very much. He lacked 26, he had weak expression of the other biomarkers, and he was a little bit concerned, and he wanted me to repeat the skin biopsy, and he had also a large lymph node. And this is the patient. Actually, when we saw this patient, I mean, you can, as a dermatologist, the flexural areas, it's very much consistent of atopic dermatitis, chronic atopic dermatitis. And he was treated, as I said before, for atopic dermatitis, for psoriasis, and there was a question of MF because of this flow cytometry. So we repeated his biopsy, and until then we usually start with treatments that do not worsen the disease if it's MF. So these treatments are either topical treatments or narrowband UVB or methotrexate. And then he had very good response with narrowband UVB. However, he has lichenified skin lesions everywhere, but the itch improved very much. So repeat a skin biopsy. And actually we did also clonality, and clonality was negative on the skin. And the skin biopsy was not very descriptive, was not very diagnostic for MF. Again, so clonality in his blood was positive. Clonality of the skin was negative, and actually we are now waiting for the, we sent his skin biopsies to Maxime Bratistella, and trying to find out if he can proceed with high throughput sequencing and find out what happens with this patient. To make a final diagnosis. So I think that with the final results, we can make a diagnosis if this patient has MF or atopic dermatitis. So this paper shows that there is no really an association between atopy and cutaneous lymphoma, and the prevalence of atopy is the same as in patients with CTCL, but we have to be sure before initiating treatment for atopic dermatitis, such as dupilumab, because patients might also be misdiagnosed, and patients might have MF as in these two patients. So MF can imitate, apart from psoriasis, also atopic dermatitis. And when we don't have response with these new treatments for atopic dermatitis, we should reconsider our diagnosis as we do with psoriasis. And this is some things we know as dermatologists how to differentiate between atopic dermatitis, MF, or psoriasis. But as we said, these things are not 100% present all the time. So CTCL can mimic other conditions, inflammatory conditions of the skin. Histology is very important. It's the first tool for new atypical lesions. Biopsy results might be deceiving and not providing definite diagnosis and have to be repeated when there is a resistant skin lesion. And we have to consider the patients with psoriasis are under immunomodulatory agents, as well as patients with atopic dermatitis at the present time receive inhibitors of antibodies, monoclonal antibodies, and inhibitors of JAK, and also have a change in their immune regulation. And as dermatologists, we need to be vigilant of the coexistence of different skin disorders, let's say psoriasis and atopic dermatitis. So I would like to thank you again. And